Hi everyone, thanks for joining. We're going to get started now. Just a reminder, we have 30 minutes and one question, one follow-up. Today we have Dr. Yaffe and Dr. Heyer here, so I'll turn it over to them for some brief remarks.
Thank you, and good afternoon. I'm pleased to be joined today by Dr. Dirk Heyer, who is the COVID-19 Vaccine Distribution Task Force member and coordinator of the Provincial Outbreak Response. I'm going to first provide an update on our most recent data and update on variant reporting, and then I'm going to offer Dr. Heyer the opportunity to provide any additional remarks if desired. So since the last update on Tuesday, Ontario has reported an additional 6,510 cases of COVID-19. That includes 3,215 cases on Wednesday and 3,295 cases today. Ontario's current 7-day average for daily COVID-19 cases is 3,093. This is up from 2,341 last week and 1,749 2 weeks ago. And sadly, we are also reporting an additional 36 deaths since Tuesday's update. That includes 17 yesterday and 19 today. The number of patients in hospital and ICU continue to increase, with 1,417 people in hospital, 525 in ICU with COVID-19. In terms of testing, almost 64,000 tests were processed yesterday, with a positivity rate of 6%. Beginning today, there is a change in how the variants of concern are categorized in Public Health Ontario's epidemiological report. The results now being reported provide a more timely and more detailed breakdown on the numbers of cases with mutations, as well as the specific variant lineages. Given the accuracy of the PCR variant test and what we now know about the prevalence of B117 in Ontario, genome sequencing is no longer required to confirm this specific variant, which is the one originally identified in the UK. This is because since we started testing for the N501Y mutation, over 95% of the specimens that were positive for that mutation and negative for the E484K mutation, over 95% of them were found to be of the B117 lineage after genomic analysis. So as a result, reporting of cases that are positive only for the N501Y mutation is now categorized under the lineage of B117. This means we'll see a significant increase in the total number of B117 cases in the report starting today. There are now 9,838 confirmed cases of variants of concern in Ontario. Of those, 9,632 are the B117 variant, first identified in the UK. 75 are the B1351 variant, first identified in South Africa, and 131 are the P1 variant, first identified in Brazil. The 7-day rolling average positivity for mutations or variants of concern is now 63.5%, which is slightly up from 63.3% 1 week ago. As noted in our update on Tuesday, and again yesterday, when the new public health measures and stay-at-home order were announced, the trends we are seeing are very troubling. The number of new cases today, 3,295, is the highest we have seen since mid-January. And when we look at the 7-day case rate per 100,000, the provincial number has increased by 27.3 to almost 121 cases per 100,000. And what is most troubling is that the number of individuals in hospital has gone up and is high, particularly those in ICU. The 525 individuals currently in intensive care is more than 100 higher than the peak we had in Wave 2 of 420. Our healthcare system is already strained, and this needs to be immediately addressed before the system is completely overwhelmed and we lose our ability to care for all the patients. Implementing another stay-at-home order and strengthening public health measures is certainly not what we wanted to do, but it is necessary to address the rapid increase in COVID-19 transmission and the risks posed by these events and the variants. These new measures will help to keep people safe while allowing our vaccination program to reach more people. By all of us staying at home and reducing our mobility, we will minimize transmission, protect our loved ones and our communities, help to safeguard the health system capacity, and save lives. So, Dr. Heyer, do you have any questions or comments before we move on?
No, I think we can turn to questions from the media.
Thank you. So we'll turn over to the media for questions.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
From Randy Rath at CHCH-TV. Please go ahead.
Hi, doctors. I have a question for Dr. Heyer. Yesterday in Niagara, it was impossible to book on the portal any appointments to get a vaccine shot for people over 60. There were just none available. We asked Niagara Health what was going on. We asked Niagara Public Health. They sent us to Niagara Health. Niagara Health responded to us today saying that when the provincial booking tool was open to adults age 60 and over yesterday, approximately 4,700 appointments were available at a hospital clinic for the week of April 12th. This is referring to the hospital clinic at the Seymour Hanna Sports and Entertainment Center. They said that for that same week, Niagara Health had reserved approximately 6,000 appointments for frontline education workers, and that hopefully by April 20th, there will be more shots available for those 60 plus. It seems that frontline education workers have overwhelmed the system so that there's no shots available for anyone else. Is that good public health policy?
So it's difficult for me to comment specifically on the individual events in Niagara because I don't have the detailed knowledge of everything that you're describing. What I can say is that what we focused on from a vaccine rollout perspective is age and at risk, and that there's clear link that the best predictor of illness is age, and certainly as the age increases, so above 80 is far greater risk than would be somebody over 60 just by age alone. But then there are other risk factors that are important to consider: where people live, where they specifically reside, and then as we move through those, there are people who are also at risk by their location of employment. And where they might spend their time working. So each public health unit has flexibility within the broader provincial direction, and at times there are particular reasons why a public health unit may approach their vaccination rollout plan in their own specific way.
Follow-up?
Has Niagara been given enough vaccine? Have they been given their share? So that, I mean, it seems outrageous that nobody 60 plus can get a shot until after April 20th.
Well, there certainly is the opportunity to go to pharmacies because all the pharmacies have the availability for upwards of 55 plus across the province, and there is a notable amount of AstraZeneca that is distributed through the pharmacies into some primary care professionals as well across the province. So there is that opportunity. We have a limited supply of vaccine. I mean, it sounds like we're awash in vaccine, but frankly, we still have a limited amount for the demand and for the desire to have vaccine, which is fantastic that people do want the vaccine and they should want the vaccine. It's our way to get the best opportunity for protection, and we have allocated across the province based upon the population and allocated based upon population across the different public health units. So everybody is getting an allocation in their population way with some potential increase for those that have been recognized as hotspot areas where there has been a disproportionate number of illness, cases, and deaths.
Next question.
From Jeff Gray at the Globe and Mail. Please go ahead.
Oh, hi, thanks. I wanted to ask Dr. Yaffe, maybe you could help us understand a little bit about what changed over the weekend. Dr. Williams and the Premier mentioned concern about the increase in ICUs just over Easter weekend in the last few days. And you can see the number, the graph line on the graph does start to go up more than it had been a bit. I wonder if you could, Dr. Williams talked a bit about how that the modeling that had been done suggested ICU numbers would have been at this point when there were many more cases than we're having each day, that they're rising faster than cases. Is that something you could sort of explain a little bit about what went into that thinking?
Sure, thank you for the question. I think that we're talking about public health measures here, and there are sort of two different strategies happening at the same time. Public health measures to reduce transmission of COVID-19 between people, and the health effects, of course, in terms of hospitalization, ICU, and deaths, and at the same time trying to get more and more people vaccinated so that we can prevent infection. So as we implemented sometime last week, the shutdown, which had some effect in terms of the health units where it had been implemented, we were hoping that would have an effect across the province. We were not seeing the anticipated effect, and the numbers were getting dangerously high, particularly in terms of the hospitals, hospitalizations and ICUs. And we were starting, of course, we see now that the vast majority, unfortunately, of our cases are the new variants of concern, particularly B117. They're more infectious between people. They have more serious sequelae in people. We're getting younger people in hospital. So we felt it was very important to have stronger public health measures put in place, and that's what happened yesterday. So we have a stay-at-home order. We also have restrictions on work, on big box stores, and we really want everyone to understand that we're hoping these measures won't, that they won't last more than a month. We want everybody to comply. Do your best. It's a tough time. Everybody's sick and tired of the whole thing. And we want to just, get out, have a nice summer. So it's unfortunate that this has happened, but we have to do what we have to do to control this virus before it gets us.
This is just, it's a really, really tough time. And so much thinking about these decisions and how hard and the balance and how do we as a province and how do we together do what we can. The public health units are over capacity. The health care system, like the highest number of intensive care units that admissions and hospital admissions. Hospital admissions are one thing. That means people are sick enough to be in a hospital, and being admitted to a hospital is an uncommon thing currently. Then to be into the intensive care unit, that's people that are at risk of dying. And so these two capacity issues, and then as Dr. Yaffe talked about, the number of cases continuing to go up, the variants of concern continuing to go up, it's a really tough time to be able to do that. While we still have vaccines, unfortunately the vaccination isn't going to allow us to exit out of this very challenging time because it takes time to get the vaccine in, but it then takes 2 to 3 weeks to develop the protection that's required. So all of those things combining, I think, were key factors that were considered by, and a decision was made from that, but it really is a tough time for everybody and recognizing that.
Follow-up?
And just maybe for Dr. Hart, just changing gears on the follow-up about the other stuff that was announced yesterday. Can you say anything about when this rollout in Peel and Toronto's hotspots for vaccinations for anybody 18 and up in those heavily afflicted postal codes. Can you talk about what shape that will take and when that will happen?
Thank you for that question, and I think really important to recognize what's driving that decision is recognizing that these are areas within the province, and there's postal codes that they're associated with, where analysis has recognized that historically over the time through the pandemic, there's been a greater and a disproportionate number of cases, illness, hospitalizations, and death. And so focusing on those areas would not only help to protect, for vaccination point of view, protect the individuals, protect their families, protect the community, and then have an impact clearly across the province on the number of cases and the number of infections. So there is very active work on developing multi-channel approaches. Both in Toronto and Peel, there already had been work in delivering vaccine to those areas, a variety of different mobile teams, pop-up clinics, public health units working together with their partners in the community, working together with hospitals to already do work in those areas. This is going to ramp that work up and really direct in multiple different ways, working together with community leaders, with faith leaders, with others that are in healthcare in those settings, partners between all of those different groups as well as the hospitals and the public health units to be able to deliver in the most effective way. Recognizing that work takes time to be able to deliver the vaccines because it's linking with the community, it's linking with the community members as opposed to the larger mass vaccination clinics, which will still continue, where people will be receiving the vaccine in a much more, a much faster way. But I think it's really important faster and both have significant impact on the importance of vaccination. So that work is all rapidly in progress and being developed right now.
Next question.
From Cynthia Mulligan at City News. Please go ahead.
Hi there. Dr. Yaffe, this is a question for my colleague Tina Yazdani. We've looked at the data today, and there's been a rapid rise in COVID cases at child care centers, with nearly a quarter of all cases in children reported in the last 2 weeks alone from the entire pandemic. How concerned are you about this rise, and what's behind this sudden surge? And are any steps being taken to slow it down in daycares, child care centers, and home child care centers?
Yes, I would say that unfortunately what's happening in child care centers is reflective of what's happening in the local communities. So we're seeing more COVID in the community. People go into the place, either their children can get COVID. Originally with COVID, we felt, oh, children probably don't get too ill. They're probably not too infectious. That has not been our experience recently with the variants in particular. So certainly we're working with the child care centers. If there's a potential case reported, the health unit would work very closely with them to get the child tested, isolated, and the cohort that the child was exposed to or exposing would be excluded. And certainly it's very important to keep maintaining infection prevention and control measures. But I think we're very much hoping that the general public health measures we're putting in place for the whole province will have a positive impact on child care centers, in addition to, of course, the vaccination program.
Follow-up?
Oh, I have 1.5 questions left, but maybe I can squeeze a quick one in and then one for Dr. Heyer, if that's possible. Are you finding children are getting severely ill? Because I'm sure parents listening to you right now will be absolutely panic-stricken. And are there young children who have been hospitalized?
I don't have specific data broken down for children. Sort of anecdotally, I'm aware of one child from a daycare who was admitted for a few days with respiratory issues. I don't think children tend to get serious infections, but they do get symptoms, and they can be infectious to others. So certainly better to prevent, and that's why we're putting these big public health measures in place.
Next question.
From Antonella Artuso at the Toronto Sun. Please go ahead.
Hello, doctors. Good afternoon.
I wanted to ask about something the Premier said yesterday. He said that by the end of the 4-week stay-at-home period, 40% of the adult population will be vaccinated. By that, I'm guessing he means a first dose. Is that threshold enough to prevent future stay-at-home orders, future lockdowns?
So double question. So yes, the vaccine supply that we anticipate receiving, and again, it's all about anticipating receiving until we've received it, does suggest through the calculations that about 40% of adults in Ontario will have the opportunity and will be receiving their first dose for that period of time. What we can't answer, and we don't have the ability to say, is whether that will prevent something as difficult as we are now experiencing with the stay-at-home orders. It's really challenging to know exactly the percentage of coverage given understanding the vaccine effectiveness, and I'll let Dr. Yaffe add into this because she probably knows it better than I do, but vaccine effectiveness, the coverage of the population, the fact that we at this point still continue to learn about whether in fact vaccination will prevent transmission. In other words, being vaccinated, as now I'm expressing my age, I have been, that whether I could still be infected with that vaccine and then transmit to somebody else, those are the things that we don't know yet. And so all of those factors figure in. Having said that, 40% of the population still is a significant number and still will clearly play a role in our management of this pandemic.
Maybe I'll add to that. Thank you, Dr. Heyer. It's hard to predict, obviously, but we believe that in order to get what we call herd immunity, it's estimated probably we need 70 or 80% population coverage. And it's very heartening to see what's our experience has been with long-term care and retirement homes, where we have achieved close to 100% vaccine coverage with residents, and over 70% as an average for staff. And we have seen a dramatic reduction in cases, in hospitalizations and in deaths. That is particularly vulnerable populations. As you know, with vaccines, it does take usually at least 2 to 3 weeks to develop a good immune response. One shot has been shown in real-world experience to result in approximately 60 to 80% effectiveness in preventing infection, symptomatic or asymptomatic, and just over 80%, maybe 85% effectiveness in preventing hospitalizations and deaths. So I think obviously if 40% of the population is vaccinated, we are significantly reducing the amount of infection in the community, and therefore well on our way to controlling this. But it's so important to keep the public health measures in place as we vaccinate.
Follow-up?
Thank you. ICU numbers, as you said repeatedly, lag behind actual cases. So there was a concern raised at the beginning of the pandemic that people who have a disability or chronic conditions would be lower down the priority list for ICU care if doctors and other healthcare professionals had to make some very difficult decisions. Has that issue been addressed?
So the healthcare system is struggling with capacity right now. As many likely know, there's people in the intensive care unit who are being transferred various places across the province, unfortunately, which is incredibly challenging for the people who are being transferred, the families, and the loved ones of those very ill people. It really leads to a significant challenge and decisions where people are receiving care are always important, in decisions that are made at the time of health care. And so those decisions will remain difficult, especially as we have an increasing number of cases in the intensive care unit and the capacity decreasing. There are a number of other things that may occur that help to protect capacity or provide capacity. But what we don't want to do is to continue to increase those numbers of people that are being admitted to the intensive care unit at this time.
Last question.
From John McGrath at TVO. Please go ahead.
Good afternoon. The Solicitor General was on CBC Radio in Ottawa this morning, and she said that the government did not act with a stay-at-home order sooner because it was waiting to see if the modeling proved out with ICU numbers in actual patients in beds. Can you explain that logic? Did the leadership, either yourselves or other people in government, not believe the modeling that was presented in February?
I can't. Thank you for the question. I didn't hear the Solicitor General's comments and really can't comment on her comments, but I will say that certainly we take the modeling very seriously. We take advice from the Science Table, from Public Health Ontario and other experts very seriously. And we don't wait to see the ICU numbers go up. We have been working very hard to look at what kind of public health measures need to be in place. Last week we put in place, or the government put in place, shutdown. And as I said earlier, we didn't see the effect we were hoping for. So we worked with, and the government has come up now with a, stay-at-home order and more significant controls. So I don't want to argue with the Solicitor General, but I would just say we cannot wait for ICU numbers to go up. That is the very last indicator before death. And what we are trying to do is keep people healthy and prevent this infection.
Follow-up, and this is the last question.
You mentioned a few times now that the shutdown came in last week and then you didn't see the results you wanted over the weekend. But throughout the pandemic, we've always been told that it would have been impossible to see the results of the shutdown only a few days later, that the results of public health measures can be 7 days to several weeks after a public health measure is imposed. So how does this make sense? What were you expecting to see over the weekend that you didn't see, and how could you have seen something so quickly?
You're right that actually to see a full impact of a measure because of the incubation period being up to 2 weeks, it can take up to 2 weeks to see an effect. What we were seeing was the slope of the increase of cases and of hospitalizations was increasing rapidly. And so we felt we cannot wait to see any impact from the shutdown. We had to act quicker. Thank you.
Thanks, everyone.